Welcome to today's webinar. County Health Rankings and Roadmaps is a program of the University of Wisconsin Population Health Institute. This webinar is brought to you thanks to the contributions of colleagues and partners in Wisconsin and across the nation, with support from the Robert Wood Johnson Foundation. It is produced in collaboration with Healthy Places by Design, an organization that advances community-led action and proven strategies to ensure health and well-being for all. The University of Wisconsin-Madison occupies ancestral Ho-Chunk land, a place their nation has called Dejo since time immemorial. UW-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the 11 other First Nations of Wisconsin. This webinar will be recorded. All speakers' views are their own. Guest bios and slides from today's webinar are available on our resource page. We will share a link to the resource page when the webinar begins. Stay up to date on all things CHR&R. Find us on Facebook, Twitter, and LinkedIn. And if you haven't already, sign up for our newsletter by scanning this QR code with your phone's camera. It's the best way to find out about upcoming webinars, our podcast, and our latest tools and resources. Your facilitators today include our host, Erica Burrows-Girardi, with support from CHR&R Communications Specialist, Colleen Wick, and the Collaborative Learning Director from Healthy Places by Design, Joanne Lee. We invite you to continue the conversation immediately after the webinar in our discussion group. Joanne Lee will be our lead facilitator. And watch for a chat from Colleen for details on how to join the group after the webinar.
Welcome to Positioning Public Health to Prevent and React to Gun Violence. My name is Erica Burrows-Girardi, and I appreciate being with you all today to discuss what I know may be a difficult and triggering topic. Please be sure to take care of your needs and know that a recording of this webinar will be available online tomorrow if you need to step away. CHR&R's webinars reflect the values we hold as part of the University of Wisconsin Population Health Institute. Values of collaboration, integrity, excellence, innovation, inclusion, and courage. These are values we aim to model during the webinar, and we hope that you will too. With that, I would like to introduce you to the team that will aid in your learning experience. Let's start with Joanne Lee with Healthy Places by Design. Hi, Joanne.
Hi, Erica, and hello to everybody out there in the audience. Thank you so much for joining us today for this really important webinar. We invite you to join the conversation and engage with us during the webinar. And there's two ways to engage. One of the ways is the Q&A box, which I will be monitoring throughout the live webinar. You can ask panelists questions by typing them into the question box at any time, and we will answer as many questions as we can during the live webinar as possible. And remember, there's also opportunities to continue exploring questions you might have about the issue during the post-webinar discussion group. Right now, I'm going to hand it over to Colleen Wick, who's going to tell you about the second way to engage with us today.
Hi, everyone. Thanks, Joanne. As Joanne said, I will meet you in the chat. Please use the chat to share knowledge or to respond to questions that we ask you during the webinar. Please make sure to join us in making the chat space welcoming by adhering to these guidelines. Share successes, lessons learned, relevant resources and links. Just make sure to engage in a respectful dialogue. As you could see, our chat conversations tend to be very engaging, so if they are too distracting, simply close the chat window. Please know that the views expressed by speakers today and participants are their own. They do not represent CHR&R or Healthy Places by Design. Once again, if you have questions for the panelists, please use the QA box. And now I will pass it on to our technologist, Erin.
There we go. Thank you, Colleen. My name is Erin Schulten, and I'm here to help with technology. So if you have problems seeing or hearing the presentation today, please send us a message in the Q&A box and we'll see what we can do to help. And I'm just happy to be here with you all on such an important topic. Now I'll turn it back over to our host, Erica.
Thank you so much, Erin, and to all of you on the production team. Gun violence is a public health crisis, according to the American Public Health Association. Let's take a moment to consider some of the factors that support this declaration. Gun violence costs Americans more than $550 billion every year. That's because of lost wages, medical care, mental health treatment, and criminal justice activities. Gun deaths reached record highs in 2021 in the US when over 48,000 people died by gun, according to the CDC. More than half, 54%, were by suicide. Another 43% were considered murder. Now, the geography of gun violence may be surprising to some. In 2021, suicide rates were the highest in Wyoming, Montana, Alaska, New Mexico, and Oklahoma, and the lowest in Massachusetts, New Jersey, New York, Hawaii, and Connecticut. What about murder rates by gun? What do we see here? Well, in 2021, they were the highest in DC, Mississippi, Louisiana, Alabama, and New Mexico, and the lowest in Massachusetts, Idaho, Hawaii, Utah, and Iowa. We often hear that gun violence is an urban problem, but the reality is no region of the country is immune. The Gun Violence Archive charts the number of gun deaths every day. And this map with the red dots represent where we stand as of this morning. I actually downloaded this morning. So we can safely say that gun violence is an American issue and we're all impacted. And I want to reiterate that we know this is a difficult topic. Please feel free to pull away if you need to. And if you or someone you know is struggling or in crisis, know that help is available 24/7. Simply dial 988. We all deserve to live in communities free from gun violence. We acknowledge that there are many ways to address it. A public health approach is one that is comprehensive and includes continued surveillance, more research around gun violence and effective prevention programs, and protection orders for those at extreme risk of harming themselves or others. We also acknowledge that gun policies have a major influence on this epidemic. Today, though, we're going to focus on a community based approach that recognizes that gun violence stems from a contagion of violence. Cure Violence is a prevention model that has effectively reduced violence, including gun violence, in multiple cities. So, with that, I want to ask you to join me in welcoming today's guest. Dr. Monique Williams is the Executive Director of Cure Violence Global, the organization responsible for creating and disseminating the model. Hi, Dr. Williams, and thank you so much for joining us.
Hello, hello. Glad that I'm here. Excited to talk to you all about this topic today.
Yep, and we will be circling back to you in just a second. But now I want you all to join me in welcoming Rana Epps, the hospital responder supervisor at King of Kings Foundation, which is a crisis management center in Jamaica Queens, New York. The organization is implementing this model. Rana, thank you for joining us today.
Hello, thank you for having me. And hello, everyone else. Thank you so much for having me today.
I appreciate you both. You can read more about our guests in the bios that they have provided for us today, and Colleen is going to chat that link out to you again so you can grab those bios. Today, here are some questions that we're going to answer with Dr. Williams and Rana. What is the Cure Violence model? What makes the model effective? And what does implementation look like? And then, like what Joanne just talked about earlier, we're going to have a discussion group after the webinar to really unpack what you've heard today. So please plan to continue the discussion with us. Joanne facilitates these engaging discussion groups, and they give you the opportunity to share with and learn from others. So Colleen will be chatting out the information at the end of the webinar so you can link to the discussion group. And with that, I want to invite Dr. Williams back to the mic and for her to start with telling us about the cure violence model.
Sure. Can you hear me?
I can.
Okay. So Cure Violence Global essentially is an organization that's really guided by the understanding that violence is indeed a public health issue, that individuals and communities have the capacity to transform themselves, and that, community partners and strategic partnerships are essential keys to success. And so through a rigorous scientific and data-driven approach, CVG helps communities to implement violence intervention strategies that have kind of significantly reduced violence over the years. And so our vision is to see a world without violence, and our mission is to reduce violence globally using disease control and behavior change methods.
And why was this model created and what makes it unique?
So we were established by a physician who was trained in infectious disease, and he previously led the intervention development unit for the World Health Organization. And he worked on intervention development for things like cholera, tuberculosis, and the AIDS epidemic in different countries around the world. And so he came back to the US for kind of a reprieve from epidemics, only to discover that, here in the US, particularly in the early 90s, we were experiencing our own epidemic, which was gun violence, and that it didn't have an adequate response or solution. And so he had kind of this innovative idea to apply epidemiologic strategies to the issues of violence in one of the most violent places in the US at the time, which was Chicago, Illinois. And so CVG, which is formerly known as Ceasefire, launched in the West Garfield Park neighborhood, which was one of the most violent communities in Chicago. And there was a quick production of results with a reduction in shootings by 67% in that first year. And so from 2000 to about 2008, CVG focused its efforts on the United States, where we expanded to places like Baltimore, New York, New Orleans, et cetera. And in 2008, we began our first kind of international adaptation and replication of the methodology in Basra and Sadir City, Iraq. And since then, international programs have been added in places like Canada, El Salvador, Honduras, Kenya, South Africa, Trinidad and Tobago. And so we've kind of been in a lot of places. And then we've also provided training in violence prevention techniques to different representatives from dozens of other countries as well.
Wow, it's amazing how you are just all over the globe. Talk to us a little bit more about the model's uniqueness.
So I'll say, right, the thing that has us here is that, it employs a scientific approach to gun violence reduction through public health theory and practice. It's really centered around community and builds capacity of the assets within the affected communities to address the violence. It leverages lived experience within the intervention, giving room and voice to both victims and previous perpetrators of violence to be a part of the solution to violence. And it also utilizes credible messengers, right? Individuals who are hired members of the community, many of which have similar life experiences to those that are at highest risk of committing acts of violence. And so these staff are trained as essentially community health workers and receive extensive education and coaching in evidence-based methods of mediation, persuasion, behavior change, and norm change, all of which are essential for kind of limiting the spread of outbreaks of violence. And of course, a unique factor is our application of evidence-based public health epidemic reversal strategies, which entails analyzing violence clusters and transmission dynamics and using these professional health workers who are culturally sensitive, credible messengers to interrupt transmission and change the community norms around the use of violence.
Yeah, and I can't wait for us to hear from Rana because she's going to talk a little bit more about what that really looks like, what you were just describing. So, you know, we hear that violence is a public health issue. And, the American Public Health Association has described it as an actual crisis. Why is it a public health issue?
So here you see kind of a list of implications that bring about the need to look at violence through a public health lens. First, there's preventable risks, right? There are both risk and protective factors associated with violence. There are things that increase the risk of being a victim and or perpetrator, and then there are things that protect against being a victim and or perpetrator. There are effects on both physical and mental health that cause morbidity and or mortality. So both illness and death are byproducts of violence. Violence adversely affects social determinants of health. There are disparities in health outcomes associated with violence. So there are certain subgroups or populations that experience violence more than other subgroups. And then, as you've already touched on, there are costs in the billions for our healthcare system due to violence, both indirect and direct costs associated with it. And then last but not least, violence acts as a contagion, which we'll dive into more deeply on the next slide.
Yeah, let's do that.
So when we say violence is contagious, we actually mean it. It's not just a metaphor. There are population characteristics that are true for all contagions, right? So there are clusters, epidemic waves, and a means of transmission. And so when we say clusters, here's what we mean, right? We mean that there are specific hotspots or areas that the issue is concentrated in. And you can see on the slide here, these are cases of cholera in Bangladesh on the left. And you can see specific hotspots there where you kind of see more cases than in other areas, right? And then next to that are cases of violence in Chicago. And again, you can see the clustering pattern of where violence is happening in certain places and not in other places. It also spreads and follows very similar epidemic waves as things like the flu or COVID, where, nothing can be happening for a while, and then a couple of events take place, and then we see these spikes. And then the most important, I think, thing is for us to understand that there's a means of transmission, right? So people aren't born violent, or there's not a bunch of people that, were born bad guys who wake up and say, I want to hurt somebody today. No, people generally get exposed to violence and repeat the behaviors that they've been exposed to. So violence meets the population criterion for epidemic disease.
Yeah, I appreciate how you broke that down and showed us the associations, the correlations. Why should we be especially concerned about gun violence? And can Cure Violence actually address gun violence?
So, it's a long-standing epidemic in the US, and it hasn't ever really been adequately addressed. And so as of 2020, we know that gun violence is now the leading cause of death for children in the US, whereas that was always, motor vehicle accidents, right? So we're losing almost 40,000 people a year to gun violence, with about 85,000 people who are left injured because of it. And so our rates of gun violence are only increasing at this point. And I mean, honestly, if we don't address it, what we see now is only going to get worse. And to answer your question, yes, Cure Violence can address gun violence, and we have done so since its inception in the late 1990s.
And I know that there's always this question about how do we intervene? How do we implement strategies? Does it matter if it's in a urban area or if it's in a rural area? So I want to ask, does the way we approach gun violence depend on whether the community is rural or urban?
So I'll say, though, there may be right? A level of kind of adaptation for context that's necessary, but the general principles and the key elements are the same. This kind of public health approach spans across different types of violence as well as different geographical locations where violence is occurring. We've applied this particular strategy to different kinds of violence as well as violence happening in different geographical locations. So, you know, everyone is really kind of affected by gun violence in one way or another, even if the type of violence that you see in rural is different than in urban. But we have effectively implemented the model in rural areas in both Canada and El Salvador.
Yeah, that's good to know. And talking about these elements, what are those key elements that's part of the model that make it work?
So there are kind of key elements at the kind of implementation of the model at the site level. And then for me, there are these kind of infrastructural things that are necessary to ensure that what's happening on the ground is able to happen. And so from an infrastructure perspective, those key implementation elements include the implementation agency. So whether that's your health department, your mayor's office, you know, there are a lot of folks who have offices for violence prevention, just an overarching entity that has the capacity to ensure that the folks on the ground have what they need. And these spaces a lot of times also have access to the resources that the individuals on the ground need. And so having this agency on board and in support is very important. You obviously have to have your grassroots organizations, right? These are the community-based orgs, faith-based orgs, whatever the organization that is going to do the actual implementation. You have to have these folks on board. And then the partnerships and the buy-in, right? So we understand violence as a public health issue. We understand violence's impact on social determinants of health. We understand that the approach has to be comprehensive. And so there are multiple players who have to be at the table when you're talking about kind of implementing this CVG system, who all in some way impact what the outcomes will be. And then obviously adequate funding. It costs, right? It costs to kind of set this up in your space, but it still costs much less than what you pay, you know, when another person is shot.
Yeah.
And so then when we look at the elements of what needs to happen in the implementation of the model on the ground, we kind of break that out into kind of three key main elements, which the first is to detect and interrupt potentially violent conflicts. And so you have your trained parahealth professionals, whether that's your violence interrupters, outreach workers, your hospital responders. You're talking about individuals who prevent shootings by identifying and mediating potentially lethal conflicts in the catchment area or the target area, and follow up to ensure that the conflict doesn't reignite. And so these staff workers, essentially, it's important for them to work separate from law enforcement, and they have to kind of remain independent in this way in order to maintain their credibility. And that credibility is needed to work with those that are at highest risk for perpetrating violence. And let's see, that second main element is to identify and change behaviors of people who have been identified as the highest risk. And so again, you have your trained staff who implement a kind of culturally appropriate and trauma-informed approach to reduce the risk of those that are most likely to commit violence and to promote health equity. And so the workers meet those at highest risk kind of where they are, talking to them about, you know, the cost of using violence, and then helping them to obtain the social services and whatever other services that they may need. And then lastly is the mobilization of the community to change the norms. And so again, those who are engaged in the strategy work to engage leaders in the community, as well as community residents, local businesses, faith leaders, other service providers, as well as those who are, you know, the focus of the intervention, right? Those that are the highest risk. And they work together collectively to convey a message that, you know, the residents, everybody involved, the community, are not in support of violence. And, you know, that looks different ways, right? So there's a response to every shooting. Communities begin to organize different events, and kind of spread this positive norm that, violence isn't normal.
Yeah, but what I love hearing is this is a multi-sector approach. So there's a role for everyone involved in this work. And I really also like the fact that you are helping the community um, create their own future. They're creating a narrative that this is not how we want to live, that we all
Absolutely.
deserve to live in a healthy, violent-free neighborhood. And I love the way you come around and support them in that effort. When you say there was, you said that some groups at higher risk for committing violence. One of the things I forgot to ask you was like, what's the age range for this particular model? Is it just adults or is it youth only?
So the age range is to follow your local data.
Okay.
Follow what your local data shows as, those who are most likely to perpetrate violence, or those most likely obviously to be victims of violence. But generally the age range has been between 16 and 25, but we've also seen like 13 to 34.
I see. No, that's good to know. I know 16 through 25, we always say that's the age range where people will make decisions that kind of impact them for the rest of their life. So if you can get them going on the right path during that time, they're more likely to make better decisions as adults. So that's good to know.
Sure.
I want to shift the conversation to the scientific evidence behind cured violence model, because this is not something that people say, oh, I just think this is going to work. Let's just try this. No, this has been studied, and there is actual evidence to shows that it's effective. So let's talk about a little bit more about that effective, what you have found.
So, the CBG approach has very strong evidence of effectiveness for violence prevention. And here are kind of a few just to highlight some of the folks who have done some research and evaluation on our work. And so today, I believe there are 8 evaluations and more than a dozen studies and reports showing large impact on violence. And so, the approach's efficacy, right, has been demonstrated through independently funded and independently conducted multi-year, multi-site, mixed methods scientific evaluations that show, right here you can see from 30 to 70% reductions in shootings and killings in the hardest hit communities in the US and abroad. And these evaluations also kind of document other positive effects that come from the work, right? Things like feelings of community safety being increased, positive parenting outcomes, improved employment and education outcomes, changes in community norms about violence, amongst kind of many other things. And so I couldn't get them all on one page, but you can visit our website to see the evidence report, which includes the additional studies and evaluations.
Yeah, and I do know that this slide isn't the easiest to read, but of course we have those slide handouts that Colleen has chatted out, so be sure to take a look at it. Dr. Williams, I'm so excited to hear that there is a violence prevention model out there that works. I'm also excited to hear that it's community based, that folks in the community can actually own this for themselves and make a difference. So thank you so much for sharing a little bit about it. Of course, we got questions that people are probably already putting into the chat. And here we have some contact information for those of you who are interested in learning more about the model. And you've actually put your email address up here. Thank you. You'll get some folks, you'll get some folks emailing you for sure. But yeah, we'll circle back to you in just a second. Thank you so much, Dr. Williams.
Thank you.
And Rana, I'd like to invite you back to the mic, because we heard Dr. Williams talk about how the cure violence model is set up. There's different roles. There's violence interrupters, there are hospital responders, but all of the people that are involved in this work are community-based folks that have been a part of the community. So I want to start by asking you, what does a day in the life of a violence interrupter look like? Like, what do they do?
Okay. Well, a violence interrupted day starts off with briefing, which is a short overview of the catchment area and its hotspots. After which the VIs are in the community canvassing, checking in with inroads, trying to identify any potential incidents that possibly can be mediated before they happen. Following up with any prior incidents to prevent retaliation, engaging with the high risk, and also trying to build those relationships so that, if, things do start to brew, we, and I'm saying as violence interrupters, will be able to get in front of such situations. The day typically ends with a debrief and documentation so that we could always just kind of track, what's going on. We don't use names and we don't identify people, but we definitely, track the data so that, we can better help with resources along the way.
So you're in the community day in and day out. I love that. One tension that I wanted to explore is the fact that violence interrupters work independently of law enforcement.
Mhm.
Dr. Williams touched on that a little bit. Tell us a little bit about why that's important.
Sure. We work independently of law enforcement to remain credible.
Yeah.
So we are credible messengers and we must be able to maintain the respect and the trust of the high risk so that we can mediate or diffuse any situations before they escalate.
And I know that this work is really hard and really requires more than just a professional commitment. Can you share a little bit about your story and what brought you to this work?
Sure. My commitment to the work comes from a lifetime of commitment to my community. So I spent a lifetime serving people, and this work is a little bit more than serving people. It's more about saving lives.
Yeah. Yeah. In this picture, what do we see happening here?
So this is a community event that we have every year. It's the King of Kings Family and Friends event, and literally, I want to say we probably have about 500 people come out. Come
That's
out every
good.
year. Yes, we actually take over the park, and this is probably breakfast. This is definitely breakfast. We have fish and grits, but it's just the opportunity that we come out and are hands on with trying to build those relationships. With the adults, with seniors, children. And it's just all about community for that day. This is one part where you see the meals are going on, but there's another part of the park where they're engaging with the music, and then we have bouncy houses, and we just pretty much take over the park: basketball, baseball, card games. Just a great time in the community.
I really like that because, first of all, I love fish and grits. But anyway, that aside. No, I love the fact that you're looking for ways to build trust. That's one of the ways to
Yes,
build trust. That's one of the ways to build connection. And we know that's so
absolutely,
important. And
absolutely.
ultimately, that helps to improve health as well. Um, so I know that Dr. Williams was talking about that the cure violence model works for youth, it might work for young adults.
Mhm.
Your program primarily focuses on youth. Is that correct?
Yes, our focus is ages 14 to 24.
Okay.
However, we don't turn anyone away. Literally, our goal is to try to bridge the gap, through community events and, bring adults, children, and seniors together, like we just spoke of.
Mhm.
But when we speak about this particular age group, we don't want to say, okay, you're 24, that's it, you missed the mark. Absolutely not.
Yeah.
So at 24, I'm sorry, after 24, you're 25, 26, 27, you still need a little bit of help. We're here. We
Right.
definitely do not turn anyone away. And we've had in our office as young as 9 years old, where, it is heart wrenching to know that we have young people who are involved, to the point that you can actually categorize them as high risk. But the greatest thing that I can think of when we think about someone at 9 years old, being a part of the high risk is that we have a team like ourselves, and we have great leadership who says, you know what, this is not a numbers game. This is, he needs us. Bring him in.
And what an opportunity to reach them and actually have that time to change the direction
Absolutely.
of their lives. So, how does King of Kings Foundation build healthy conflict resolution and leadership skills in the youth that you serve?
Peer mediation. We train in peer mediation, and we teach participants to mediate their own conflict. And I'll defer to this picture exactly, where, we've had youth, out with us and just trying to show them how, and teaching about consequences. Well, we actually teach a little bit more. We teach about choices, consequences, and what's at stake. Our foundation center, we look to build strong decision makers, teaching the youth to think things through with key points. And those key points, again, are choices, consequences, and what's at stake. And it's just important that we continue to build those relationships, and by teaching them how to deal with conflict and how to mediate for themselves, they always look back and say, you know what, let me shoot over to the King of Kings because I have a particular situation going on. And sometimes they come in and they ask for one of the VIs or the OWs by name, when they know they got a certain situation, they come, let me talk to you for a second, And
Now,
so
what's our OW?
works. OW is our outreach workers.
Oh, okay. Okay.
Right. Our outreach workers, they work with the youth, the high risk, long term. And so sometimes they have these situations that occur, and they say, you know what, I really need somebody that I can talk this through with. And they come back and they say, hey, I need you. And that time is allotted for them. And just one key point that I do want to say when we talk about OWs, which is our outreach workers, our violence interrupters, and our hospital responders. No matter what the situation, we always drop whatever it is that's going on at the time so that we can assist. There's nothing too small, because anything that's small can always turn into something big if not addressed when necessary. So we never turn anyone away, no matter how small, someone might think it is.
And I love how you are helping young people in your community take a pause. Let me take a pause. Let me think this through before I react. So I love that, and I love that you all are making this space for those young people to come and talk things through and learn how to have that mediated conversation. Um, Really, really good work.
Thank you.
Earlier, when you and I were talking, you were telling me something very, very special about this picture. And I don't want to tell the story, it's your story to tell. But can you share a little bit more about this picture? I know this wasn't something we had planned to talk about in an interview, but I really like what you told me about this picture.
Fine. No problem at all. So we had the young people come in, and I'm not sure if everyone can see the gentleman all the way to the back. So he's a pilot, and he's six. My son always tells me I don't know heights, but I want to say 6'9". He's about 6'9", and he grew up in the same neighborhood. He grew up in Jamaica Queens, and all throughout his college education, they kept saying to him, you are bound for the NBA. And they wanted him to play in the NBA. And he said, absolutely not. I want to fly. And right now he is a pilot, and we brought him in just to expose the children to how many choices that they have. He had two choices. He was not pointed out and said, you don't have options. No, he had a choice. He was offered a career playing basketball. And he said, absolutely not. I think I can do something else. And the thing that I want to do is make this dream come true of flying. And that's what he does. His mother's always scared to death. His mother is always scared to death. She said this was the only moment that she wasn't afraid for him coming inside the community and speaking with the young people and telling them about, his goals and how he made it through and how he slept, in countries just so that he can get an opportunity to train to fly for free.
Yeah. The reason why I love that story is because you are showing the youth right there in your community. There's so many choices, and work hard and be able to do the things that you want that's going to fulfill your dream. And I thought that was such a lovely example. And I love the fact that he came back to
And
his own neighborhood.
and you
That
know
is
what I
just
want
beautiful.
I want to just stress also about this picture. If you notice, and this is one thing that I want everybody to recognize, they want it. They
Yeah.
want it. They want it so much that we're talking about. This was in the middle of COVID. If you notice,
Mm.
everybody has a mask on and they still came.
Yeah.
They still came. They want it. It wasn't, they were not mandated to come. One of the youth said he wanted to be a pilot. I knew this kid, this young man, I knew his whole family, so I reached out to him. He said absolutely. And when we told the youth that he would be there, they came. And it did
Wow.
not matter to them at that moment in time that you're looking in this picture. Um, None of their gang relationships mattered. They just wanted to see a pilot
Yeah.
and
Yeah.
to see like him.
What a wonderful way to bring people together. Yeah, you all do such good work. Some of us that are on this webinar are not necessarily in violence prevention work. So tell
Mhm.
us, what can we in public health do about gun violence, even if violence is not the focus of our work?
Well, the first thing that I would always say is educate, create an awareness for people to understand that violence is a disease. And the second thing I would say is get involved. Let's start pushing the narrative that violence affects everyone. Sometimes people, have this ideology that violence doesn't affect me because I live in a certain area code, or violence doesn't affect me because I'm not a part of that type of lifestyle, but violence affects everyone. And then let's just get involved. Uh, the third thing I think I would like, I think would be really great if the support the effort of changing community norms by using platforms like this to show the impact of the work that we're doing. So I
Yeah.
think, that's that's exactly where we are right now, right? Showing that support, saying, hey, we recognize it, we see the work being done, and let's go ahead and support the people who actually do the work. So I think that we're in a good space on that one.
I appreciate that advice. As I think about everything that you said, you are rooted in your community. Um, you have always loved serving your community.
Yes.
You are actually seeing change happening in your community as a result of implementing the Cure Violence model. You being able to see young people lives change. So, one of the questions I want to ask you is, what gives you hope for Jamaica Queens' future?
I hate to sound like this, but our leadership. Our
Leadership is
leadership.
important.
Yes, our leadership. And knowing that, we have a caring staff and caring leaders, right?
Yeah.
Um, the most important thing I think is that knowing that we have a team of people who are rooted in the community, who work cohesively, going above and beyond to keep our community safe. Every one of us has a vested interest in our community. And I think that's one of the things that, really brings hope. And I've said it time and time again, and time again. I've been proved to be correct. We've had young people come to our doors, and we've brought young people in. And by the time 2 to 3 days, maybe even a week go by, this young person is someone's grandson, someone's niece, someone's nephew. So I think, that has been the thing that is really gonna push us to the next level, because now we have that community buy-in, because the community is saying, hey, you know what, they helped my grandson out and they didn't even know
Yeah.
he was mine. They helped my niece out and they didn't even know she was mine. And so now they're saying, you know what, let's see how we can get involved. And I think that is what really is going to take us to the next level as a community in South Jamaica.
Oh, that's so beautiful. We are all connected, and what you just shared proves that. So, thank you, Raina. Thank you so much for what you
I'm
do and
happy
for the
to be
King of
here.
Kings Foundation there in Jamaica Queens. And so, right now, I would like to invite Dr. Williams back to the mic so we can see what questions might be percolating in people's minds.
Thank you so much, presenters. And Erica, are we taking questions for both presenters at this time?
Yeah, we can do that. We have
Okay,
time to do
thank
that.
you. And so, folks, there are a lot of questions, probably more than we have time to get to, so apologies in advance, but we are going to do our best to put similar questions in composites, but remember there's always a discussion group if you want to continue the conversation. And so I will start with you, Dr. Williams. And Christopher wondered, are there best practices to actually convince local and state leaders to shift to a public health model for cure violence instead of over-policing as a response, or having leaders talk about other solutions rather than money and time going into law enforcement and not public health?
There are. I think a big one would be mobilizing and organizing, right? So gathering as much information as there is out there, because there's a lot of information out there now about addressing violence as a public health issue, all of the different places that are engaging in this type of a strategy, and elevating those voices to the folks in your jurisdiction who are decision makers. I've seen that happen a lot in cities, right, where the community's voice is elevated, and if council members want to keep their seats and different things of that nature, you know, it's kind of how they get them on board just a little bit, and then depending on whose ear you have, connecting to folks like, you know, Cure Violence, we have a model and we do a lot of work, but you know, we're not the only ones out here kind of doing this work and engaging with folks who have community-based, community-driven models for violence prevention and intervention, and you know, bringing us into spaces to have conversations with leaders and legislators who may not be having this discussion yet. But I think it's the kind of combined power of the people, and people realizing that power that they have when you come together collectively with one voice about a particular topic that is of importance to you.
Yes, and I think the beauty of the CVG model is that it is evidence-based in its approach, and there's lots of evidence that it works. Yeah, so advocacy, that really helps with advocacy. Okay, the next question, Dr. Williams, I think we'll start with you, but Rana, if you have experience with public health partners, it would be great. Dr. Jim, you know, really appreciates hearing about these community relationship building programs and wants to know how local health departments or local public health folks can actually take lead roles in addressing prevention and gun violence.
So I'll say that in a lot of our places, a lot of the initiatives are birthed out of public health departments, right? And so when I talked about that implementation agency, while they aren't the agency and shouldn't necessarily be the agency that like hires interrupters and all of that, because there are a lot of ways that they have to operate that sometimes go against the grain of the red tape of government entities. But that government entity can be the one to bring it into a space or to bring it into a city. So we are reached out to a lot of times by health departments, and then we work with health departments on building out what the infrastructure within their jurisdiction needs to look like, so that bringing together of what partners need to be at the table, what community-based organizations should be at the table, and we kind of work collectively to help build out the necessary infrastructure to make sure that what happens on the ground is successful. And another key part of it being kind of tied to public health are the resources that are available within a public health department. When you think about, a lot of the times there's access issues for our marginalized communities, and you build this strategy in partnership with a public health department where they then prioritize the needs of those that are being worked with in the population. And then of course, right, the data center, public health, and what they can provide from a data perspective. So there are some real ways and real-time ways that local and even state health departments are being engaged, and as a funder of the work, that kind of help to make the work successful on the ground.
Wonderful. Thank you so much. It was great to hear those very specific examples. So Dr. Williams, stay on because I'll probably come back to you, but want to switch to Rana. People were just really inspired as you described the work and your commitment to it. So one of the first questions is about the relationship with law enforcement. So Dr. Williams mentioned how violence interrupters and outreach workers need to be able to operate independently from law enforcement. So what are those communications or with law enforcement like, and the relationships with law enforcement like? Oh, you're on mute, Rana.
Thank you. So on the ground level, our violence interrupters, they don't have any relationship with the police department at all. But sometimes there is a need for the police department when we're talking about community events and so on and so forth, because we would have to use the police department to make things safer when we're talking about safety in the community, as far as blocking streets off. So it's not that we are against the police and what they do. No, that's not it. It's just that when we're talking about dealing with the high risk, we don't want to lose that relationship with the high risk that the police may never have with them. And so if they feel like we have a relationship with the police, then they're not going to want to deal with us. And then we have the next act of violence perpetuated. And that's not what we want to do. So we do have a relationship, but not on that level. The street level, absolutely not. But when it comes down to safety in the community in regards to uh, events and so on and so forth, then yes, we definitely have to utilize the services of the police department, but not on a street level, not at all. They actually may not be able to go into those tight places that we can go into.
Right. Thank you for that. So you folks have heard this term a lot in the presentation, high risk. And Emily wanted to know how do you know what qualifies as high risk? Can you give some examples?
Sure. Geographical location, inherited trauma, gang affiliation, know someone who's in a gang, hangs around with someone in a gang. Some of these things are what we look for when we talk about high risk. We would like that they at least have four of a category of 7 high risk factor indicators.
Okay, that's helpful. And then as Dr. Williams showed with the maps, also just look for hotspots in the community because you mentioned geography is part of that, part of the factors. All right, big question, Reina. How do you find or recruit violence interrupters?
Can you repeat that? You were breaking up. Can you repeat that? You were breaking
Yes,
up.
how do you find and recruit violence interrupters?
So I think, yes, Dr. Williams did speak to where we get violence interrupters. Most of the time, violence interrupters are people who have lived that lifestyle before. They were the high risk. We use this quote all the time. I used to be the problem. Now I'm a part of fixing it. So we're talking about people who used to be a part of the lifestyle and are now coming back and saying, hey, yes, I am who I am. You do know me as such. And now I'm trying to turn things around and make the community a little bit better, a little bit safer, because I used to be the problem. And now I'm just trying to make things better.
Yeah. Good. Okay, I think this is for both of you. Anna said the approach, Raina, your program is so great. How would you recommend that communities that maybe don't have a relatively high rate of gun violence, how can they adopt elements of this program as a preventive measure? Have you seen that done?
So I'll let Dr. Williams answer in regards to seeing it done, but I honestly think that this program should be adopted by anyone who has or any level of this in their communities, because it's helpful and it really works. I use the word helpful. I want to take it back. It works. one thing that we do at King of Kings is we stick to the model. We have not strayed, and every single time we've had positive results. It is a work in progress and in process, but the reality of it is the model works, and I think that it would, do everyone a service, taking it on at any level. And I think even, the earlier the better. You don't want to wait till things get out of hand to say, you know what, I think we should go ahead and try to get involved. And, I come from a space where I think, nip things in the bud. If it's growing, you should go ahead and start right there.
Absolutely.
And I'll just add to that, right? It's an effective part of a system that can be very preventative. And so while we always come into spaces that are right from the map where violence is high because we're trying to kind of reduce what's happening, if you're kind of seeing an onset of something and there's an opportunity to get in front of it, I will say from a funding perspective, right? A lot of times people aren't necessarily giving to the spaces where, the disparity isn't the worst. And so again, we kind of follow the data and implementation, but absolutely from a preventative lens, right? The basis is relationship and building relationships with folks and learning how to kind of de-escalate situations that could potentially turn violent. And so having these skill sets and these kinds of training is going to be beneficial for any space, extremely high violence or low violence.
Applies to a lot of different social determinants, right? Okay, Rana, this is some very specific folks. I think you got them thinking about how can I do something similar in my community. So folks wanted to know how many VIs and OWs do you employ, and where do you get funding to support King of Kings?
Okay, so first let's start with, we have 2 sites, and it comes from the data if we have to look at the bigger picture, right? The funding comes strictly with the data. Where are they seeing higher rates of violence, and how, where is the need? That's what's important. Where's the need? And that comes from the data. And then as far as violence interrupters, we do have 2 sites. We have a Jamaica site, and we have another site in another part of Queens, which is Rosedale. And I want to say at our Jamaica site, we have about, I think 10, we have about 10 violence interrupters in our Jamaica site. But again, remember, there's 3 disciplines. It's not just violence interrupters, it's violence interrupters, hospital responders, and outreach workers. And so that team of 3 is also at both sites, right? That's the model, that you would have those 3 disciplines. And so I would say each site, well, the Jamaica site, we have at least 25 staff members at our Jamaica site. Let's just focus on that site. We'll just focus on Jamaica. We have about 25 staff members, and BI is the most of the staff. Yes. But if you're looking for, go ahead, Dr. Williams.
No, I was just going to add that, even making determinations about how many staff, that also correlates, again, like Rana said, with the data and the size of the catchment area, like what makes sense, right? Because these people are out, they are walking the neighborhood, they are engaging, and so it has to match, right?
Yes.
Whatever the target area is.
Yeah. Thank you so much. So Erica has come on, which is my cue to stop the Q&A, but thank you so much, both of you. It's clear that you generated a lot of interest.
Yes, thank you so much. And some of you might be curious about what data measures that we have available at CHR&R for you to explore what's happening in your own county. Check out this measure. It's called Firearm Fatalities, and that would be on your county snapshot at countyhealthrankings.org. Also, we have What Works for Health, which is our database of strategies. So check out ways that you can address gun violence at that database, you simply have to use the keyword gun violence. When you do, you're going to find a number of strategies. And guess what strategy you will also find? You will find more about cure violence when you go to What Works for Health, because we know that cure violence works. And so that's a database of evidence-rated strategies, and cure violence is definitely included. So please share your thoughts on today's webinar. Colleen is chatting out a link to a brief evaluation, and that would be, it would be terrific if you can click on that link and just complete the evaluation after the webinar. We do look at your feedback closely and use it to improve our webinar. So thank you in advance for sharing your thoughts with us. Now, let's talk about next month. Well, climate change is happening, but together we can mitigate its threat to our health and community. So join us next month as we explore local health and equity approaches with Dr. Vivek Chandas. He's a professor and researcher from Portland State University, and he will be here talking to us about what we can do about climate change. Again, this has been a great discussion, so please continue to, please plan to continue it with us in the discussion group, and Joanne is going to facilitate that. Again, these groups are very engaging. Dr. Williams and Rana are planning to join us today, so Colleen is chatting out a link to the discussion group right now. And be sure to stay in touch with us through social media and by subscribing to our newsletter. So I want to thank Dr. Monique Williams and Rana Epps for sharing their wisdom with us today. And thank you to all of you. And I want to thank you for what you do to advance equity in your communities. I hope to see you in a discussion group, and I certainly look forward to seeing you next month. Bye.